Good evening. Croeso cynnes y chi gyd, noswaith dda. A very warm welcome to you all. Thank you for joining us for the 2023 Wales and Africa Health Links Network annual lecture hosted by Tony Jewell and organised by Hub Cymru Africa. My name is Dr. Julia Terry and I'm the interim chair of the Wales and Africa Health Links Network. This event is in a webinar format, which means that at the moment only panellists can share their microphones and video. So all other attendees are therefore unable to share their microphones or video. We do want you to participate. I know you'll be listening well, maybe making some notes, and we do want you to please use the chat box function at the foot of the screen so that you can just click chat and post in any questions or comments that you may have. Separately, you may want to ask a specific question to a member of the panel or a panelist, and so you can click Q&A in the meeting controls as well. And you'll also be able to view other questions that attendees have asked, and you can also vote for things that you agree with or want to challenge. So please feel free to send in questions throughout the event, and there'll be an opportunity later for panellists to have some further discussion. We really do value your feedback, and so there will be a feedback form appearing in English and in Welsh, which you can find in the chat. Please note, Hub Cymru Africa operate a safeguarding policy available on request, soon to be available on the website, and we do not tolerate any forms of offensive or abusive behaviour. That includes any inline comments posted in the chat boxes as well. Hub Cymru Africa reserve the right to mute or remove participants, should that be necessary, who present a safeguarding risk, and we want you all to know that at the start of this evening. So I will now hand over to Tony Jewell. Tony is a former Chief Medical Officer from Wales. He is also a former chair of the Wales and Africa Health Links Network and a fellow of the Royal College of GPs. Please note, everybody, we will be stopping firmly at 7 o'clock this evening. So we wanted you to let you know that at the outset. So diolch yn fawr, and please enjoy the lecture.
Thank you very much, Julia, for that introduction, and good evening, everyone. I'm Tony Jewell, as Julia says, and having stepped down as chair of the Wales Africa Health Links Network in 2017, I was asked to set up annual lectures for the Health Links Network. And over the last 5 years, we have covered some very important topics, including surgery in conflict areas, global inequalities, the climate emergency and sustainability, maternal and child health and sustainable development goals, and war, peace and health. And I'm delighted this year that we're going to look at another really important issue, which is decolonising healthcare solutions, looking at low-cost innovations from the countries, low-income countries. I'm delighted to introduce Dr. Matthew Harris, who is a clinical senior lecturer and honorary NHS consultant in public health medicine at Imperial College in London. He has had extensive global health experience from being a family doctor in Brazil in the 1990s, a WHO immunization consultant in Ethiopia, an HIV technical advisor in Mozambique, a UK global health advisor, and a Commonwealth Harkness Fellow in 2015. He's published over 150 articles, and his recent book, Decolonising Healthcare Innovations, is well worth a read. And so unashamedly plugging this for Matthew tonight. So we've got a really good speaker tonight on a really important issue for us to understand what decolonising means. And I'm sure Matthew will give us some examples of the two-way exchange of ideas between Wales and Sub-Saharan Africa. Matthew, thank you.
Well, Tony, thank you so much for that really generous introduction and for the invite as well from Claire, Julia, and others. for this evening. It's an absolute pleasure and an honour to be giving this lecture today on the topic of decolonising healthcare innovation. And I'm going to cover off a few topics. I'm going to talk about what are the low-cost solutions that we need to be paying attention to, and the reasons why, and then also be asking some important questions, I think, about why that's so hard to do, and then give, I think, at the end, some solutions, some strategies perhaps, as to what we can do about that in order to improve our uptake of low-cost solutions from low-income countries. I'm going to start by reflecting actually on the fact that when I qualified in medicine back in the late 1990s, I think the NHS budget was something in the region of about £90 billion per annum. It's currently running at about £160 billion per annum. And I read last week that actually we need double that in order to sustain the NHS moving forward. And I asked myself the question, where do we draw the line in terms of how much we plough into healthcare? I'm not saying that we shouldn't invest in healthcare, but I'm saying there does need to be a little bit of downward pressure, particularly on some of the very highly sophisticated technologies that we seem to always want to use in the healthcare service, at least from a UK perspective. And I'd like to just make the point and argue that actually there is another way of doing it called frugal healthcare innovation, which is all about achieving exactly the same clinical health outcomes and patient level outcomes that you would like from the technologies that you're using, but at a far lower price point or cost, if you like, to the health system. And the way that frugal healthcare innovation does this is by, I suppose, sacrificing some sophistication or functionality around the technologies that don't have direct relevance to the outcome that you're interested in. So sometimes these frugal innovations tend to be much more simple. They might be repurposing technologies from other functions or other areas, using local resources, maybe more lightweight or more rugged. They might not be quite so sophisticated and have quite such exciting technological functionality as some of the technology we use in the UK. But as a result of that, actually become far more affordable and without scrimping on any aspects of safety or clinical effectiveness as well. So what I'd like to do is just start by giving a few examples, notable examples from around the world of frugal healthcare innovations, just to sort of reinforce that point. What are we talking about when we talk about frugality in healthcare? So here's a really good example that I like to talk about, first of all, in the area of orthopedic surgery. And this came from Malawi originally, and Uganda, in fact. And it's essentially, in orthopedic surgery, you have to almost always drill a hole with a drill at some point. Here in the NHS, we actually use very expensive technologies. These silver drills at the top of the screen cost in the region of £30,000 each, because they can be baked in an oven and sterilised in their entirety without actually damaging any of the electrical equipment on the inside. Whereas in contexts such as Malawi and Uganda, where these technologies weren't affordable, they've just been using hardware drills in orthopedic operations, but wrapping those drills, which obviously aren't sterile, inside a sterile bag. And that bag is reusable and re-sterilizable. And as long as the drill bit itself is sterilized, then actually the risk of infection is exactly the same as the more sophisticated technologies that I mentioned earlier. So we actually calculated what would be the potential savings for each NHS trust in the UK if we were to routinely use this type of technology compared to the expensive one. And we estimated that about £200,000 per annum could be saved by each NHS trust if they swapped out this technology. In fact, if you were to overnight swap out all the orthopedic drills that we use in the NHS with this solution, we would save about £100 million, which is an awful lot of nurses. Here's another example from general surgery. When you have an inguinal hernia, you have to use a type of mesh. It's made of polyethylene and has holes in it and pores in it, and it's used intraoperatively and it remains in situ inside the abdomen in order to prevent the hernia from recurring. But they're actually quite expensive here in the NHS. We actually spend about £100 on each segment of commercial mesh because it comes in a sterilisable, pre-packed, pre-cut format. That's quite expensive. whereas mosquito nets are actually made of exactly the same material. They're still made of polyethylene or polypropylene, very, very similar. And in actual fact, mosquito nets, if they're not insecticide treated, they actually have very similar biomechanical properties to the abdominal wall. Now, a mosquito net costs only about £12. You could cut thousands of appropriately sized chunks of mesh out of a single mosquito net. And we calculated that actually pro rata would actually save about 10,000 times the amount we spend on mosquito nets here in the NHS. Clinical trials comparing the two different types of mesh have actually shown identical outcomes. Here's another example. Saiba's method. This was devised by a Bangladeshi obstetrician for the treatment of postpartum hemorrhage. And here in the NHS, we spend about £200-300 each on balloon tamponade devices. These are the ones on the left of the screen. They're commercially available, they're quite expensive. You insert the catheter into the uterus in this obstetric emergency, you inflate the balloon with saline, it exerts pressure on the inside of the uterus and stops the bleeding. It turns out, though, that if you just tie a condom to the end of a catheter, cheap as chips, it's only £1 each. It does exactly the same function. You can still inflate the condom in exactly the same way, and it saves just as many lives. And this has been being used in Bangladesh for many, many years. Now, here's another example. This is in plastic surgery. So again, here in the UK, if you suffer from a 2nd or 3rd degree burn, you'd ordinarily need to have some type of skin graft, either a porcine, so pig skin, or cadaveric skin graft, so from a human. Or you'd have to have an autologous skin graft, so somewhere else in your body, which would be very painful because you have to remove it. It's also very expensive. And it turns out that tilapia fish, now tilapia fish is ubiquitous, is abundant in the Brazilian Amazon, and it's very, very rich in different types of collagen. Brazilian researchers have actually just been shaving off the skin from the tilapia fish, and it's a byproduct of its consumption, sterilizing it, placing it on top of burn, and it's evidenced extremely good re-epithelialization in very complex burn situations. Then we spend £8 billion a year in the NHS on burn treatment. Imagine how much we would save if we were just spending $11 for a course of treatment. So these, I think, are quite interesting examples of frugal innovations. They're examples of how we may repurpose technologies from some other area, use resources that are just available around us, ingeniously improvise some technologies into a surgical environment. It's a really interesting way of innovating. And we find that actually results in far, far more affordable solutions to that which we're using in the NHS for equal outcomes, essentially. But one of the problems I want to just raise is that we very rarely, actually, it turns out, pay attention to the countries that are devising and developing these sorts of solutions. And I want to argue that actually our gaze in the UK is very firmly fixed towards the West. So I'd spend a little bit of time looking at significant policy reports that some of you might already be aware of. Take this one, for example. This is the WaAHLN report that came out in 2002. And I poured through the report just to sort of work out, well, which countries are mentioned in terms of international comparisons for the WaAHLN report here in the UK NHS. And it was simply France, Germany, Netherlands, Sweden, Australia, Canada, and New Zealand. Here's another example. This is from the Commonwealth Fund, which is actually a US healthcare think tank. And each year or every 2 years, they produce reports comparing different countries and their performance and their structural characteristics, just to see kind of which countries are doing better. But I think what's interesting is that the only countries that are ever included in these reports are pretty much the same ones as in the WaAHLN report, all Western, North American, or Australia, New Zealand. Here's another example. This is the NHS long-term plan, even more recent. Some of you will be familiar with it. And again, the only countries that are mentioned in this report are the same sorts of countries, so basically Western European countries. And I just think that's quite interesting for a couple of reasons. The first is that it's kind of always the same countries. When was the last time a politician in the UK actually stood up and said, isn't it amazing what's happening in Malawi, for example? It just doesn't happen. But the other thing that I think is really interesting, if we go back to the reports I just mentioned, is that the logic that's explained for why these countries are included predominantly is quite interesting. So, for example, looking back at the WaAHLN report, the only justification for the countries that was given as to why they were being used for comparison is that they had broadly similar levels of income per head of population. But actually, at the time of publication, the Faroe Islands, Greenland, Guam, and Puerto Rico all had similar levels of income per head of population as these countries, quite interestingly. But those weren't chosen to be mentioned. Here's another case, so back again to the Commonwealth Fund. The only logic that was provided to justify the reasons why these countries are being included was based on the dollar spend on health per capita, or the percentage GDP per capita on health. And the logic being that these are comparable on both of those metrics. These countries are comparable. But at the time of publication, again, Cuba was spending $2,900 per capita on health. And Uruguay, Suriname, South Africa, and Sierra Leone all had pretty similar percentage GDP per capita on health as the other countries that were included. So it just sort of begs the question, doesn't it? Why weren't those countries included at that time, if that was the logic? And my final example is looking again at the long-term plan. The only logic that was provided to explain why, in this instance, Germany was being compared with the UK regarding leg amputation rates was because Germany happened to have twice the rate that the UK had. But again, at the time of publication, KwaZulu-Natal happened to have twice the rate of leg amputation rates as the UK. So why wasn't that country compared in that instance? So the point I'm trying to make here is that if we have an interest in actually, and then we have a concern in the exploding budget of the NHS, if we have an interest at all in looking to frugal healthcare innovations as potential solutions to that exploding resource requirement, without scrimping or sacrificing any issues of clinical outcomes, we need to ask ourselves, why are we not looking to the countries that actually do that frugal innovation really very well? There seems to be what we call in textual analysis, we seem to be having what's called a structured absence. It's only certain countries are ever included when it comes to international healthcare comparisons for the UK context. It's always the same countries. And the other thing that's interesting is that there's this thing called ix-nomination, which means there's no apparent need to really justify it. It just is. And I think that's a bit of a problem. So we looked at, a few years ago, we asked US healthcare policy makers, who do they look to when they look for inspiration, and what were the reasons? And they mentioned a number of countries, all the same sorts of ones. And I thought that this was quite an interesting takeaway message in terms of the logic that as to why they pay attention to what's going on in Canada. Canadians look more similar to the US. Many more Americans have been, the visuals are similar, they're relatable. There's a likeness that makes people more willing to see that it could be applicable. Or you could picture a school in Canada being like a school in the US. So really what they're saying is that because of certain parameters that seem to be similar between Canada and the US, that seems to be sufficient to pay attention more to Canada than to other countries. But I just wanted to make a point here that logic, whilst understandable, is very much what we call a heuristic. It's very much a mental shortcut, cherry picking one dimension only in order to justify a previously held belief. This is a paper that came out back in 2018 in JAMA. And there are two things that are quite interesting. The authors were purely looking to describe healthcare systems across the world in terms of workforce characteristics, structural capacity, population, demographics, and disease prevalence and other things like that. And they basically ranked and categorized a number of countries according to multiple different domains. Two things are interesting here. The first is that the same countries were included in this report as the ones that I've just mentioned. They're all Western countries, okay? But the second, I think, really interesting thing here is that against all of these different domains and characteristics and features that are important when we think about healthcare and healthcare systems, whether it's the how GPs are remunerated or how many MRI machines are there per head of population, yeah? None of these countries are consistently similar to each other. They might be similar to one another on one domain or one dimension, but definitely not on another. And that's just on workforce capacity. If we look at spending profiles, we see pretty much the same picture. And if we look at population health and demographics, life expectancy, maternal infant health, no countries are the same. There is no discernible trend in terms of whether one country is or isn't more similar to another. So to cherry pick a certain league of nations, should we call it, consistently and routinely and enduringly for international comparisons on the spurious argument that they're more similar to each other for some reason, I don't think really holds. I think this is a heuristic. And I think the reason why we have this heuristic is because there's a very clear core and periphery in global health. So this is an interesting cartogram that came out in 2012, which shows how research is consumed around the world. The size of the country essentially represents the number of citations that research from that country has received. So essentially, it's a complex picture, but that reveals a number of different interesting things. The first is that there's very significant skew, isn't there? There's a very significant skew between the global north, let's call it, and the global south. There are countries in the world that, even though they produce a lot of excellent research, and they're not having their research cited or consumed. So I'm talking about countries in South America, and of course countries in Africa, and also in the Indian subcontinent and in Asia, Southeast Asia. This is a function of lots and lots of different things, of course. It's a function of how much research is being produced. It's a function perhaps of the quality of the research that's being produced. But it's also going to be a function of the fact that research is predominantly published in English, that it requires an awful lot of resources to produce high quality research, and resources, as we all know, is distributed unfairly around the world. And so really what this slide is showing, I think, is that we're living in an echo chamber. Essentially what it's saying is that the more we consume research from certain regions of the world, the more we're going to understand that actually those are the regions in the world that we need to be paying attention to. But I think what that also means, the risk, is that because of that echo chamber effect, we're missing out on learning from lots and lots of really important countries. There, of course, this issue is compounded, I'd say, by how certain countries are represented in international development and, of course, in the media. But what this means is that we end up having a very deeply held, I think, and entrenched attitude that global north has expertise, it has highly sophisticated technologies, and other regions in the world perhaps don't, and maybe are the recipients, the beneficiaries of our knowledge. I think this is really represented beautifully in the word reverse innovation. So reverse innovation is the name given, traditionally it's been given in recent years, to the idea that an innovation that originated in a low-income country and then can then be adopted into a high-income country context. And this has been termed as a reverse innovation. But it's interesting because that really, I think, reveals that deeply entrenched idea that innovation would normally only flow in one direction, which would be from the global north to the global south. So when it happens the other way around, then that is a reverse innovation. So we use terminologies like this, I think, a little bit sometimes unthinkingly, but they're useful to pay attention to because it surfaces some other assumptions that we have about how knowledge flows within global health. Tony mentioned already that I was a GP in Brazil, and I talk about this issue of decolonization in global health with some degree of discomfort because at the end of the day, and I'm going to come to this in a minute, it's Eurocentrism, it's also white Eurocentrism, and as a white middle-aged male educated in elite institutions in the West, I feel somewhat complicit in this phenomenon. But I lived and worked in Brazil for many, many years, in the northeast of Brazil, in a deeply impoverished area, and I became a Brazilian GP. I speak the language, I learned the language and passed all the medical school exams. And I was deeply impressed when I was working there by their use of community health and wellbeing workers. I had 4 in my practice when I was working in Recife in northeast Brazil. And they were phenomenal. I couldn't have done my work without them. And the reason why is because they are locally recruited healthcare workers, providing universal and proactive outreach to 150 households each across a life course approach of health and social care support and prevention. These are local lay people trained and paid. It's a rapidly deployable innovation, easy to scale. They provide comprehensive support at the household level and visiting each household in their areas at least once a month, and deeply integrated to the primary care team. It's highly scalable. Brazil now has over 250,000 community health workers covering 75% of the population, and they've seen remarkable outcomes in terms of population health, particularly around cardiovascular disease mortality. When I returned from Brazil, I could see immediately that there were opportunities to address many challenges that we had in UK primary care, whether it's around widening entrenched health inequalities, unequal access and experience, the workforce crisis of which we're definitely experiencing at the moment, and all sorts of issues around a fragmented and expensive care within the primary care level. But for many, many years, the reactions that I got, I think, reflected some of these deeply entrenched attitudes. What could be possibly learned from a developing country like Brazil? Does it even have a health system? It would work in Brazil, wouldn't it? They're much more friendly and community oriented. And it really took about 15 years to overcome some of those deeply entrenched attitudes before we've been able to, and just in the last 2 years, pilot the Brazilian community health and wellbeing worker approach in exactly the same way that they do in Brazil, starting in a very deprived council estate in Westminster, but also scaling now into other localities around the country, such as Kensington and Chelsea, Lambeth, Bridgewater, Calderdale, the Scilly Isles, Cornwall, Somerset, Wales, Bristol, and many other areas are all at different levels of their implementation, but all seeking to implement this model. It's just a shame it took so long for it to gain traction. And I think this is because we have of this deeply entrenched attitudes within global health, a bit of an us and them situation. We somehow believe that frugal healthcare solutions, such as the community health and wellbeing worker model, such as the drill, such as the mosquito net, they are cheap and therefore they are for low-income countries. And that misses a really important opportunity for us to actually not only deliver high-quality care, but also to deliver high-quality care at an affordable price point. And I think if it's good enough for use in a low-income setting, it should be good enough for use in a high-income setting. I wanted to just tease out some of the and surface some of the assumptions that we see throughout global health and some of the research studies that you might come across. This is the conclusion of one of the randomized clinical trials that I mentioned earlier in the use of mosquito net mesh compared to commercial mesh for hernia repair. And in this randomized controlled clinical trial published in the New England Journal of Medicine, they found that there was absolutely no difference in clinical outcomes between the mosquito nets and the commercial mesh. So no increase in adverse events, no increase in infection rates, et cetera, But it's interesting to me that their conclusions were that this, therefore, use of the low-cost mesh should be used in resource-scarce settings. And I asked the question, well, if there's no difference in outcomes and it's a fraction of the cost of what we're using in the UK, why on earth only resource-scarce settings? Here's another example, again from one of the studies that describe the condom catheter approach, Saiba's method, compared to the balloon tamponade devices that are available commercially. And they found exactly the same thing, that success rate, a very reasonable price compared to the commercial offerings, and therefore it could be used in low resource settings. There's never any question that it could maybe be suggested for use in the high income setting. But I think there's other thing that's interesting, which I'm going to call about attribution, which I just want to surface here. Because when innovations come from low income settings, I like to just highlight what I've noticed, which is that they tend not to be attributed as such. They tend to just be sort of discounted. The condom catheter solution was invented by Saiba Akhtar, a Bangladeshi obstetrician, and actually predated these commercial devices. In all of the studies that talks about Saiba's method, they never refer to it as Saiba's method. They only refer to it as a condom catheter device. And I just think that's quite interesting, because it's not like in surgery or in obstetrics, we shy away from eponymously named technologies or syndromes like the Blakemore tube, the Foley catheter, the Chamberlain forceps, the Leverett forceps, the Keeland forceps, even the Pfannenstiel incision. But when it comes to a Bangladeshi obstetrician inventing something ingenious, somehow her name is erased from that technology and that solution, which is very unfortunate. It's interesting, and Sahiba Akhtar herself has noticed that actually now condom catheter devices are being packaged and sold back to Bangladesh and other sub-Saharan African countries by the Gates Foundation at $5 each, which is curious because it doesn't cost those anything at all when used locally. So I think there's some really interesting questions there around how development assistance might be working here in this space. So this is all well and good, but it's all a little bit anecdotal. How can you actually prove, how can you actually ascertain whether or not we do have unconscious biases, prejudices, whatever you want to call it, against low-income countries and the solutions that they develop? Well, we produced an implicit association test, a computerized methodology that looked at whether or not people have unconscious associations between high-income countries and good research or low-income country and bad research. And this platform has been used for many other socially important purposes, such as identifying whether we have unconscious bias against white names or black names or preferences towards men or women in terms of their associations with science or liberal arts, whether we associate men with careers and women with families, whether we associate white faces with positive valence or black faces with negative valence. And this research has shown that, yes, we do against all of those things. And our research showed that actually we do associate, on average, high-income countries with good research and low-income countries with bad research. It's automatic, it's unconscious. We might not even be aware of it. Does it, though, manifest in action? Does it manifest in choices? So we actually used a robust scientific method to ascertain whether we're being scientific in how we assess science. So we did a within individual randomized controlled crossover design study, essentially asking English clinicians to rate 4 research abstracts one day, and then a month later ask those same people to rate the same research abstracts a second time. On the first time, we listed those research abstracts as having author affiliations from either high or low-income countries. Second time round, we reversed those affiliations. So those individuals got exactly the same content. We just changed the author affiliation from either a high to a low-income country. We asked them 3 questions each time, the same question. How strong was the evidence in those research abstracts? What was the relevance to them? And how likely would they recommend it to a colleague? And unfortunately, we found that on all accounts, on average, when rating the research abstracts from a high-income country, they just simply rated it better on all 3 measures, which undermines the way we conduct science and might even be explaining how we learn and translate knowledge from around the world. And all of this, of course, is rooted in the same sorts of roots that we have with racism. I wouldn't say it's necessarily racist, but it is of a type. And it's to do with colonialism. It's to do with the emergence of the modern Western episteme back in the 15th century, where at that time, the logic, the cosmology, we might call it, emerged of the notion of modernity. It emerged in the 15th century. Modernity, modernness, advancedness is not a real thing. It is not what we say ontologically real. It is a concept that we have constructed ourselves as human beings, but that gave a logic to then colonize different countries around the world. So the idea that the Western cultures were modern and advanced gave the logic, gave the permission to then colonize other cultures that were perceived to be traditional or primitive. Now, modern, let's call it medicine, has emerged within that context. So white male patriarchal systems were all established at the same time. The scientific method is intimately related to colonial expansion, not just in terms, of course, imperialism and colonizing countries by managing disease epidemics and plague surveillance, but through the very logic of modern medicine being and perceived as superior and Western superior to other knowledges from around the world. And I think what we're seeing when we see research abstracts being rated far worse because they come from a low-income country, we're seeing this manifestation in practice, as unconscious as it might be. So what are the links with racism? Well, Victor Ray describes this really well and nicely in his theory of racialized organizations. In the same way he describes that you can think of ethnic restaurants or black banks, organizations can have a race. Organizations can be viewed as racial entities. The journal Nature last year described themselves in a moment of reflection, excuse me, as a white institution. And it's not because everyone in there is white, of course not. What they're meaning by that is that they are part of the mainstream scholarship. Nature, like Imperial College, like University College London, we are part of a mainstream sense of what knowledge is and what constitutes knowledge. And that is essentially being referred to as part of our whiteness at an organizational level. So essentially, we could argue that when research abstracts are rated worse, because they come, let's say, for example, from the University of Mzuzu in Malawi, it's because we are unconsciously viewing that organization as a non-white institution, as a non-mainstream institution. So we're already predisposed to discounting its outputs immediately. It's entrenched. So all of that is a little bit sad, and it's all very complicated, and it's all maybe requires a lot of attention. And then there are ways to actually address some of these really complex issues. Andreotti refers to these as either being soft reform, which is all about thinking of equality, diversity, inclusion, thinking about being more inclusive with our knowledges, being more introducing knowledges and research from many regions in the world, so that we can be more diverse in terms of our knowledge base. But this doesn't require any actual major shift, because we're still just being more open to including knowledge into an existing mainstream. Radical reform, she refers to, as something that actually requires a major shift. That's actually about asking about power. It's about how do we constitute the fact that we have a mainstream knowledge within the West that dominates? How do we recenter knowledges from around the world? How do we do away with the idea of a mainstream at all? And that requires major shifts. And then there's a beyond reform, where actually they suggest that the whole of modernity needs to be put in a hospice and reinvented. Capitalism, democracy, the whole thing is at the root of all of this, and the violences that it produces against different cultures around the world. So just giving some examples of each of those, apart from the latter one, because I think that's quite dramatic. But the example of a soft reform is this one at Imperial College. We created, I think in a world first, the opportunity to convert higher education institution reading lists that we provide for students into machine-readable code that allows you to plot instantaneously the geographies from where all the authors on those reading lists have originated from. So that invites you to be able to ask important questions around whether or not your reading lists are diverse. Do you need to ask important questions around, should we be more inclusive about where we're learning from, where we're teaching from? Then there's ideas around reciprocal innovation in contrast to reverse innovation. This is all around how in international health partnerships, we can actually recenter what constitutes knowledge and power within the context of international development. And we can actually create innovations that are mutually beneficial between both the high-income country and the low-income country contexts. Similarly to this, we've done some work with the Tropical Health Education Trust that provides a toolkit for actually people that volunteer within partnerships to actually explore this in more detail, dismantling the us and them dynamic, how to create a learning environment, how to prepare healthcare professionals that are visiting overseas in such a way that any biases that might be prevalent won't interfere with their identification of solutions that they might be actually observing in the local context that could be relevant back in the NHS. International health partnerships are phenomenal vehicles for the translation of knowledge between both the global north and the global south. So it's really important to capitalize on those opportunities. And then finally, we can take a decolonial lens in everything that we do by creating an environment and a culture of epistemic pluralism. That is to suggest that we critique evidence-based medicine. We locate it in its historical context. We understand that evidence-based medicine is a belief system, just like every other belief system. We practice cultural safety, critically reflecting on the power in every interaction, even the doctor-patient, particularly the doctor-patient relationship, in order to decenter, recenter power within all of global health. that's my final slide. And it was really just to say that if anybody wants to, as Tony mentioned, if anybody wants to explore some of these themes in more detail, I've covered a lot of what my book discusses, but obviously there's a lot more detail available in my book that is readily available on Amazon and elsewhere, should you choose to explore some of these themes further. So just my final takeaway message here before turning off my slides, Tony, is just to say, we can't keep complaining of ever-increasing costs within the NHS. It's not sustainable to keep investing and throwing money into the NHS when we are also using technologies that actually we don't necessarily need to use for the outcomes that they produce. The second point is we need to learn how to do that better from low-income countries that have been doing more with less for a lot longer than we have. We need to start thinking of ourselves as a resource-poor context. We need to start looking to other settings that have been struggling with their resources for a long time in order to identify those ingenious solutions that they've devised out of necessity, but that nevertheless perform just as well as what we do here in the UK. And then finally, we need to really reflect on the coloniality within our own higher education institution systems, how we're training and teaching our students to pay attention to regions in the world that have been otherwise, up until now, I think, unfairly rendered rather invisible to the Western gaze. Thank you.
Thank you very much, Matthew. And I think we're handing over to Claire or Julia to field some of the questions that have been posted. So if people can use the Q&A on the bottom of your screen to load up questions that Julia or Claire will field. Thank you very much, Matthew, for excellent talk.
Matthew, I hope you will forgive me if there's a lot of sound in the background. I've had to come to a cafe to connect to an internet connection, so I'm trying very hard not to, and it's freezing, so I've got my coat on. I am going to hand over, I'm keeping an eye on the Q&A box, and some of the questions that have come through aren't necessarily totally clear in their meaning, but I'm going to hope, Matthew, that you can interpret them. But I'm going to start off, if that's okay, with one question. I read your book in anticipation of this lecture, and you asked an interesting question in your book about reverse innovation, and is there a better term for it? As Hub Cymru Africa, we've really struggled with that term specifically before we'd even read your book, actually, because of the implications as you're kind of touching on in your lecture. I'm interested in your views on the role of academia and of practitioners changing language and being conscious of the language that they're using, because words have meaning, as we all know, and you're obviously questioning the language. Whose responsibility is it, do you think, to kind of change it, and what can people on the lecture today potentially do in that space? And then I'll keep an eye on the other questions coming through just to kick off.
Yeah, thanks so much, Claire. That's a really, really important question. I mean, I think how definitely I agree with you. How we use language is so important. It's down to all of us, really. I wouldn't say that it's any one organization or institution has responsibility for it. We all have to be very reflexive of the language that we use. So reverse innovation is an interesting example because it was actually coined more as a management strategy for big international corporations who have subsidiaries in low-income countries, for example. And so that term was used to suggest that if they leverage their subsidiary organization in a context where regulatory barriers might be lower in order to innovate for certain technologies or solutions, then they would then be able to cannibalize their own markets back in their home countries in high-income settings, subsequent to that, once the proof of concept of those technologies has emerged. And that's where the term reverse innovation came from. But it's sort of been co-opted in health policy circles to a large extent, and probably not particularly sensibly for the reasons, Claire, that you mentioned that I described as well in this presentation. But nevertheless, I think it's also quite helpful sometimes to have these terminologies to signal what are the deeply entrenched values that we still nevertheless have. Reverse innovation, I sometimes still use as a concept in my lectures, purely to make the point that is in fact representing a deeply entrenched hegemony. Obviously, there are other terminologies: bidirectional learning, mutual reciprocity, just learning. knowledge translation, knowledge diffusion be far more, I suppose, have less valence to it, won't it? And we should all start using those sorts of language. But the fact of the matter is that there is valence still in global health. Until such time, I would argue that a UK Prime Minister stands up and has as much chance of mentioning Malawi as he or she does of mentioning the United States. I would argue that we still haven't yet got parity in terms of regional representation in our collective consciousness. So I think, you know, the skew in global health knowledge diffusion is so huge, like that cartogram that I showed you. Until that actually becomes more equitable, I think sometimes these terminologies are quite helpful as a point of departure to start entering into discussions about the inequities within global health knowledge systems.
Thank you, Matthew, and for the answer on that. I'm going to go through the questions as they're coming through in reverse order, and there's a couple of similar things coming through, so I'm going to bunch them together. And the first one's from Catherine Thomas, who I know you've met, Matthew, and she was the previous chair of Wales National Health Links Network, so it'll be familiar to most people on the call. So she's thanked you for your contributions, and there's lots of food for thought. And then she said, how well do you think we are doing with decolonisation in the research community in the UK at the moment? And how do we deal with helping those who are most privileged to be getting out of the way when this could have a personal high cost?
Catherine, thank you so much for that question. It's lovely to have you on the call. Nice to see you. Really important question. Look, you know, like I said earlier, I'm a white middle-aged male, you know, educated in elite institutions, and I'm talking about decolonisation. There's a lot of people talking about we need to decolonise the decolonisation debate, because it's people like me that are talking about decolonising. And I don't think these are mutually exclusive issues. This isn't a zero-sum game. I think we all need to be involved in this situation. We all need to be reflecting on how power operates within global health at every single level, whatever your characteristics are. I should say that I've not benefited in any way by entering into this debate for many, many, many years. I actually really struggled to get my voice heard, that as a Brazilian doctor trying to translate innovation into the UK. And that gave me a palpable sense, I think, of what it must feel like to be a colonial subject, I would say. What it must feel like, the unfairness of not having your knowledge, your expertise, your insights really being listened to. So I think this is work that we all have to do. It's not just certain types of people. It's something that we all have to be part of. I think decolonising has really exploded within the UK over the last few years, and I think that's a really good thing. I think we still need to do a lot more. We're doing a lot in terms of, I suppose, looking at curricula design and trying to be more inclusive. I'd love to see more around data-driven approaches to decolonisation, if I'm honest. I work in a STEM institution and where data speaks volumes, right? So I'd love to see more about that. At the moment, decolonisation seems to be much more rooted in the humanities and social sciences, where they're more attuned to asking some of these really complex and difficult questions. Whereas scientists, doctors, you know, we're not quite so familiar with these concepts in a funny sort of way. We respond better to data. And I think we need to find good ways of actually using data to demonstrate, like we tried to do at Imperial, at just how extreme some of these skews are in terms of regional representation in global health.
Thank you, Matthew. It's definitely a discussion we've been having in the section Wales, is that colonisation was a Western structure and we created it, so we have to play a role in deconstructing it as well. And it's learning from other people, but also taking a role in it as well. And that's really important, particularly when you have a position or a privilege or a platform. So thank you. Christine Glossop has asked a couple of questions, and Christine, I'm going to ask your first one, and that's the one I'm not totally sure about, because I think it was placed when you were speaking and I can't quite tie it back to what it was, so we might need more clarification, but you might understand it, Matthew. And she says, what about health visitors who are doing community public health work? So if that question makes sense, answer it. If it doesn't, Christine, please put a clarification in the box.
Thank you, Claire. Thank you, Christine, for your question. I think I understand, but forgive me if I get this wrong. We have lots in the UK. We have an awful lot of healthcare and social care professionals that work within the community. And it's easy to think that community health and wellbeing workers are really just more of the same, but they're not. And I'll spend a moment just explaining why. We have health visitors, we have health trainers, we have peer support workers, we have community champions, we have social prescribers, link workers, care navigators. There's no shortage of people working in the community. But what we don't have, what's the missing link, and this is where the community health and wellbeing worker comes in, that Brazil's excelled at, and many other countries as well, is somebody who can go door to door in a small geography and just build relationships with the people that they are responsible for, knocking on their door once a month, having a cup of tea and saying, how are you today? By building those relationships, and believe me, we will all need a community health and wellbeing worker at some point, because things happen from one month to the next. But by building those relationships, by being paid full time to do so they have a mandate, by being integrated into the primary care and social care system so that they have an ability to refer people with issues into the wider workforce to resolve them, by looking not just at single clinical conditions like many of our healthcare professionals do, based on referral or based on a priori knowledge of what people have or their age groups, by looking at the whole household, they become the missing link in the NHS in order to help all of these other health professionals do the work that they do much, much better and more efficiently. So we think what's working well now in London and in other regions around the country is that this community health and wellbeing work being integrated in this way is actually really supporting households interface with the health system better, more effectively, identify the unknown unknowns, people who have problems that we didn't know about, and help our existing healthcare workers do their job a lot better.
Thank you, Matthew. I'm going to ask you one more question, and then I'm going to hand back to Julia as the chair of Wales Africa Health Links Network. It's just summarised. We know we're finishing at 7 o'clock this evening. So I'm sorry to people whose questions I'm not going to ask, but we do have an open channel to Matthew. And Matthew, I'm sure you'd be happy for us to send some questions across, and we can send a roundup email afterwards with the link to the YouTube video with any interesting points that have arisen. Lots of people commenting on kind of like the wastage within our system. It's like when you've got resource, then it's easier to kind of waste, I think. There's some comments on the language and things used. And I'm going to go to Jeff Lloyd's question, who runs quite a big programme in between Wales and Uganda. And he's talking about, now you can hear an announcement, this is really embarrassing to try and be doing this with an overhead sound, about using motorbike ambulances in Uganda to provide simple, cheap alternatives to get patients to hospital quickly. He's talking about an incident where someone recently dislocated her hip at 10 p.m. on the road on the night and was told it'd be 7 hours before an ambulance could get there. I'm presuming that's in Wales, Jeff. Surely there were low-cost solutions to the problem of ambulances parked in A&E for up to 12 hours. And Peter's just said it's hard to hear me over the announcement. So what's the reverse innovation, I guess, for the UK in terms of ambulance waiting times when they seem to be more efficient in countries where they're able to use motorbike ambulances and things like that?
Thank you, Claire, and thank you, Jeff. And I can hear you perfectly fine, Claire, so don't worry too much. Jeff, it's a really, really point. I think there are two opportunities for reverse innovation here. Sorry to use the word, but it's a shorthand. The first is that actually the community health and wellbeing workers, funnily enough, are a solution to this problem. One of the reasons why ambulances are stuck in A&E for 12 hours is they can't offload the patients that they have in the ambulances into A&E because A&E is too full. And A&E is too full because the people in A&E who are looking to be admitted can't be admitted because people in the wards are blocking beds because they can't be discharged. So the whole system is clogged up, okay? Now, community health and wellbeing workers, because they visit households daily, are available immediately for somebody to be able to be, once they're discharged from hospital, to be visited, check in on them and make sure they're okay, all right? So if we had this universally across the whole system, across the whole country, I anticipate that you would have a much better situation around bed blocking, which would have an upstream solution, if you like, to this issue around ambulances not being able to offload their patients. But you're right, motorbikes being used as well as ambulances in many countries is a fantastic idea. And we should be using it in the UK, subject to all the necessary, of course, safeguards and so on. But it's a fantastic idea. I don't see why not.
Thank you. I'm going to take myself off camera and hand back to Julia to just finish off the evening. And I'm not going to do the thanks either. I'm often stepping into chair role accidentally. So thank you, Matthew, and back to Julia.
Thank you so much, Matthew and Tony, for this evening. It's been extremely illuminating. And if people haven't already, please do have a look for Matthew's book, Decolonising Healthcare Innovation. The low-cost solutions, particularly interested in the word frugal. For a long time in Wales, we've talked about prudent healthcare, and that seems to have slid rather from our activities. But of course, I'm very interested in how we have become so bound up with bureaucracy and systems that it has really crippled organisations and workers for wanting to do what are very often effective actions. I see this happening well in the third sector, where they perhaps have just as much governance, often more than some of the main areas. But we really know that we have become so bound by paperwork and processes that it really does serve to disable innovation. So the reverse innovation is something that we really need to be looking at much more greatly. I was privileged to be in Uganda earlier this year, and just seeing how well the community health and well-being workers, how that can work in terms of people locally knowing communities and the needs there, and how that can impact on areas like vaccination uptake, mental health, and thinking about addictions, just a whole host of areas of health where we really want to be seeing people's health improving and making a difference. So I would just like to extend my thanks to Hub Cymru Africa for helping to organise and to promote this event, to Tony for hosting, to all of you for joining this evening, and particularly again to Dr. Matthew Harris for his insights and contributions, and giving us a huge amount to think about this evening. Thank you very much, everybody, and good night.
Thank you.